Liz is a consultant breast surgeon, and she was diagnosed over 10 years with breast cancer. And she started this blog just to come to terms with the diagnosis. But now she writes formally and talks about her experience. And Liz was nominated for Woman of the Year in 2016. Alongside that, she is an award-winning author, and she's co-authored a book which covers everything you need to know about breast cancer and how to empower them through treatment. And it's packed full of lots of tricks and tips. And that's the one thing that draws me to Liz, is how practical Liz is. So I know we're going to learn quite a wee bit this morning from her. Liz is also a very keen advocate of exercise in cancer. So I'm going to hand you over, Liz.
Thank you very much. I'll just share my screen. So I'm going to talk to you today about why I think exercise should be the fourth cancer treatment and why I have such a passionate interest in it. When I was 40 in 2015, I was a fit, healthy triathlete. And I went from that to a stage 3 breast cancer patient overnight. And despite being a breast cancer consultant, having spent 20 years of my life training to treat it, thinking I knew everything about it, I realized I knew absolutely nothing. I had no idea what it was like to go through all the treatments I was giving my patients. And I realized as a doctor, I'm very, very good at telling patients what will happen to them, but I had no idea what to do to help them cope. And when I was diagnosed, I told Twitter. I couldn't keep it a secret, and it meant that my husband could get the support he needed. I wasn't ashamed of having cancer. And people reached out to me, giving me advice, telling me how to cope. And that advice and my own experience has changed how I think we should treat cancer as a whole. You know, if you told me 10 years ago that I'd be here talking about exercise, I'd have told you to go away. I wouldn't have believed you, because I was the girl who did no sport at school. My maiden name was Ball, as in football, but I couldn't hit, catch or throw one to save my life. Sport was a dirty word. I did a bit of swimming when I was younger. No balls were involved. And I ran the London Marathon when I was 30 for a local hospice. I had no idea what I was doing. I hadn't run more than half an hour before. It took me about 6 hours to get around. That was that. And then I met my husband, and he started cycling. And I realized that if I didn't start cycling, I would never meet him, because he'd cycle all morning and then sleep all afternoon. And where was I? I was a cycling widow. So he bought me a bike, and within a year we were doing 100-mile bike rides, and I was hooked. But I got bored because cycling was his thing and I wanted something for me. And I thought about triathlons, because I've done the London Marathon and I used to swim a lot. And I bought, a typical surgeon, I bought every single book, I read every single magazine you could. And in my head, I was a triathlete. And my husband got bored of me faffing about and signed me up to do one before my 40th birthday. And this was it. And I loved it. The sheer madness of swimming and then cycling in a wet onesie and then running afterwards. I just had the bug. I loved how exercise just made me feel free. And when I was diagnosed, I thought, can I really give all that up? I'd signed up to do a half Ironman triathlon, and it was meant to be 2 months into chemotherapy. And I just thought, I can't lose this. Now, I'm ashamed to say, as a doctor, I never talked to a patient about exercise, ever. Wasn't my job, didn't think I should. I didn't even check to see if my nurses were. It just wasn't on my radar. And when I was diagnosed, no one talked to me about whether I could. And I turned to Twitter, and I found an amazing woman in the States called Suzanne, whose handle is Athlete on Chemo. And she's got metastatic breast cancer. And she would cycle to the gym and do weights and then kayak and run. And she was so active. She was still a teacher having treatment for Mets. And I thought, wow, if she can do that, surely I can do something. I met other professional cyclists who had cancer, who were still cycling and racing through treatment. And Kate Granger, who some of you may know, she's now sadly died, behind the Hello, My Name Is campaign, emailed me and said, Liz, the one thing you have to do is to walk every day. You have to keep your fitness up, and there's days when you won't feel like it. And so I started. Every morning at 6 o'clock, I walked with an amazing neighbour before her kids went to school. And some days I couldn't walk more than 300 yards without stopping to cough and spit, but I did it. I earned the right to sit on the sofa. And as my weeks went better, I started doing park runs. This is me and my husband. And I'd never done park runs before. And I turned up bold as a coot, and this amazing man came up and gave me a hug and said, "Welcome to the Cuddle Club." Now, he had metastatic sarcoma. He'd had about 50 operations. He sadly died earlier in January this year, but I suddenly realized there were these amazing people who were running, and it was the most fantastic community. I was really slow. I was at the back. It didn't matter. It wasn't a race. It's something I did with my husband to think, cancer doesn't take everything away from me. I can still do crazy things like this. I did one of those crazy 5K color dashes where I got covered in powder paint, and I did my triathlon. The picture on the left is me doing a sprint triathlon halfway through chemo. Now, this makes me sound like an amazing athlete. I'm not. It was halfway through chemo, so I still had a bit of energy, and it was in a local pool, and I had to beg my local cycling club to let me do it. I had to promise that I would stop if I felt unwell. I wasn't racing. My husband would be there to look after me because they were concerned. They'd never had someone on chemo exercise before. And the beauty of the pool-based triathlon was the slowest people went off first. So even though it took me 2.5 hours, I still finished before the people who'd won. And I swam every length, breaststroke, pausing at the end to get my breath. It was a really slow cycle, waving to everyone instead of heads down racing. And I slowly waddled every single step of the 5K. And that feeling when I crossed that finish line, it was just, I was crying, my husband was crying. I just felt, today I'm Liz. I'm not a cancer patient, I'm not a breast surgeon, I'm just me and I'm alive. And a year after treatment, I did the half Ironman for charity. Now, I hate the colour pink. I hate it, let alone it's pink for breast cancer, but I wear it for charity, and I race this with a big pink neon wig on my head. And it's a 1.2 mile swim and a 56 mile bike ride and a half marathon. And I did it just under the cutoff of 8.5 hours, but I did it just to prove that I could still exercise. And the feeling it's given me has just carried me through. But it's not all about how it makes me feel. It's how we can improve the quality of care of the patient, quality of care we give our cancer patients. And as a surgeon, I thought quality was all about doing the right thing at the right time, getting pretty scars to show at conferences and making sure I didn't have a lot of complications or take-backs to theatre. But that's only 2 parts of it. And the third part of quality is the patient experience. And yes, I was very concerned about the patient experience whilst they were in my clinic and in hospital underneath my care. What happened and I said, bye, see you in 5 years, wasn't my business. That was the GP. But that's the time when cancer patients struggle the most. And it's the time when I struggle the most, when someone says goodbye and you're suddenly thinking, how do I know if my cancer is going to come back? Can I work again? Can I have sex? Can I exercise? What should I be doing? And I started looking at cancer charity websites, just wondering, is it actually safe to exercise? Because I didn't tell my doctors what I was doing. I thought they'd tell me to stop. I was under the radar doing my own thing. And I realized doctors don't get training in how to tell healthy people to exercise, let alone cancer patients with various comorbidities and treatments. So it's no good asking your doctor because they won't know. And most doctors don't exercise. And if you don't get how good it can make you feel, you might not tell that to your patients. That led to me writing a book that Eilís mentioned with Trish Greenhouse. She's actually the woman behind all the COVID mask evidence. She's amazing. She's an academic GP who was having chemo on the same day, and we just wanted to share how we cope. And there's a chapter in here about exercise, covering aerobic exercise, weights, yoga, how it can make you feel, if people want a basic how-to. But there is so much evidence now, and you're going to hear more of that later from Gillian, about why exercise should be the fourth treatment. They have taken, and this is a PDF you can find on the Macmillan website, of all the evidence to download, along with things that you can use when you're seeing patients to help guide them. There was a trial that took 70-year-old men going to have resections for lung cancer, and they put them on exercise bikes 2 or 3 weeks before the operation, just pedaling for an hour at their kind of VO2 max, a heart rate kind of 130, 140, just for 2 weeks. Those doing the exercise got out of hospital quicker, had fewer complications, had fewer infections. The benefits of exercise can start at the day of diagnosis. I've seen trials where they've put men having chemotherapy for pancreatic cancer actually cycling on a bike during the infusions itself. They have fewer complications, less neutropenia, they have the full dose. It reduces the side effects of treatments. It's the best thing for fatigue. It's the last thing you want to hear when you're exhausted, but exercise has been shown to improve how you feel. It also has a massive effect on the anxiety, the depression, the PTSD. For me, it was a massive thing just to get outside in the fresh air and feel healthy again. But it's not just that. It can reduce the risk of recurrence by 50% in breast, colon, prostate cancer. That is something that patients can do to take control of their illness. I know we give chemotherapy to patients in breast cancer if there's a 5% benefit at 10 years, but exercise can reduce their risk by 50%. It also improves bone health. It is the fourth drug, and I think if you're not prescribing it to patients, we're doing them a disservice. This is a busy slide. If you're looking on an iPhone, I'm sorry, but there was a huge international roundtable with 3 papers published at ASCO last year, based on all the evidence they found, telling us what cancer patients should be doing and why. And in a nutshell, you need to be doing aerobic exercise 3 times a week, half an hour at a time, getting your heart rate up. And that means that you can only talk, a bit like Trump, in 2 or 3 or 4 word sentences. So you are getting out of puff. But the most important thing is the resistance exercise. It's the weight training. It's the one that seems really, really hard to do, but that is what's going to improve your strength, improve your bone health, especially in the metastatic community. Because if you can't walk upstairs and you can't stand up off a toilet, you're not going to be able to be looked after at home. And it's looking after your legs. So things like squats and lunges and calf raises that people can do at home, they don't need to get into a gym, that can dramatically improve their quality of life. But most doctors have no idea how to prescribe this. You tell a patient to go and do aerobic exercise and weights, they think, what do I do? But I think one of the beauties of the pandemic is there are so many exercise videos now online that you can do and you can follow, showing you how to do body weight exercises at home. We need to encourage patients to get to the local gyms, to try and find physios who can help guide them, because it will make a huge difference to their quality of life. I struggled to know what I should do. I wanted to find people, and I didn't know how to prescribe it myself when I went back to work. And this is a slide from a talk that Sarah Weller gave. Now, this is her Twitter handle. She is a clinical exercise physiologist who specializes in oncology and exercise and cancer. And she's set up a cancer recovery program in Vancouver. And she put up this slide to show how in 60 seconds, anybody could assess a patient's exercise program, what they're doing, and guide them. You ask them what they've done in the last 7 days, and you remind them, have they done the aerobic exercise? Have they done the weights? You then advise them, you remind them what they should be doing. And if they don't know where to go, you can then refer them to people to find help. And that can be the hard bit as a doctor, because you have no idea what people can do. I know for breast cancer, we often have moving on programs. Local leisure centres will offer programs for patients, reduced exercise classes. You can go and do some research and find out what's available for people in your area, so you can signpost them. But just if everybody did this every single time you saw them, are you doing your exercise? Have you done it? Have you put it in your diary? Can you get your family to do it with you? It will make a huge thing to improve the quality of their life when we've given them all the amazing treatments. I'm about to launch a website for a charity called cancerfit.me, because I think it's very lonely having cancer. If you don't meet anyone else having treatment, you don't know what other people are doing, you don't know what's possible. And we've got stories from patients all over the world, about 40 or 50 at the moment, with cancer of every type, every stage, telling us what they've been doing. And you've got the athletes who are diagnosed, who are still doing Ironman, to the 80-year-old ladies who started doing park runs. There's the 5K Your Way regime that I hope a lot of you have heard of. Park runs are every week before lockdown, obviously, where you can do a 5K in your local park with a load of people. And what 5K Your Way is to try and get cancer patients to do it on the last Saturday of every month. And it was launched in Nottingham by a friend of mine, Lucy Gossage, who's one of the UK's top triathletes, but she's also an oncologist. And at the first one, there was a 70-year-old man with prostate cancer who'd come along because she'd bullied him in clinic, and he brought his wife. And it took him an hour and a half to walk that 5K. But when he crossed the line, he put his hand up in the air and said, today, I feel like me again. Today, I don't have cancer. And that's the power of introducing patients to others, to doing it together, to realizing what you can do. We need to make sure people do this. It is so important. I just want to end by saying, exercise is often a dirty word. And it's very hard to encourage people to exercise when they're dealing with all the side effects of treatment. But we now know there is so much evidence to show that we're doing them a disservice if they don't. And ideally, we'd all practice what we preach as well. Thank you very much.
Liz, thank you very much. I mean, I think as I listen to you, there's so much in that from your role as a breast care surgeon and that transition and new knowledge from the experience of a patient, and then the exercise itself, both the psychological and mental health, but also the therapeutic effect. I really like the line that, you know, today I feel like myself again.
Yeah.
That is a very, very powerful line.
I think you get so hospitalized, and it's all about treatments and appointments and blood tests and scans, and it's all anybody ever talks to you about. How are you? How's the cancer? Actually, I'm Liz. I'm not a breast cancer patient. I have an identity, and exercise is a way just to be free.
So I could talk to you for the rest of the session, but we're not going to, we're going to leave that to after Gillian, but thank you very much. Thank you. So moving on to Dr. Gillian Prue. Gillian and I worked together many years ago, and she's now a reader at Queen's University in Belfast. As a physiotherapist, she has an interest in exercise and oncology, and she's currently running trials now in exercise with prostatic, pancreatic and ovarian cancer. Gillian?
Great, Liz, and hopefully what I'm going to talk very briefly about also complements what Liz has been speaking about. She obviously talked very broadly about exercise and cancer, and I just thought today it might be useful to focus in on one cancer particularly when we're looking at prostate cancer and some of the evidence around that and some of the trials that are going on at the minute. So I'll speak a little bit about exercise oncology and the idea of exercise as medicine and where that has come from. We'll look at some epi data around exercise and physical activity and how it can influence cancer risk and survival, and then that leads on to some of the current prostate cancer trials that we're running at the minute. But one of the crucial bits I think that it's really important to think about and consider are implementing this type of work and particularly what we've been met with in the past 6 months or so with COVID, and how we've overcome some of those obstacles as well, and also the idea of exercise and it being a behavioural intervention and the difficulties as well with that. Okay, so the first thing to kind of think about is this idea of exercise as medicine. And as Liz has already spoken about, this an idea as a treatment for cancer. And really, whenever we think about exercise and we think about exercise as a cancer treatment, we can think about it in two different ways. We can think of it in a synergistic way, so this idea of actually increasing the effectiveness of other cancer treatments. And Liz had mentioned one of these about people, you know, on exercise bikes while they're receiving their chemotherapy, and exercise has been shown to actually enhance the drug itself, as well as actually making people fitter and increasing their tolerability to treatment. And it seems that it does that by increasing the blood supply and the vascularization of the tumour, so it helps the chemotherapy actually in that drug delivery mechanism. We're also, there's some evidence, and we're starting to also think about ways of making radiotherapy more effective in this synergistic way, and it's exactly the same idea that they don't want tumours to become hypoxic. If there's the oxygen is there, it makes the radiotherapy more effective. So if we can get people to exercise, whether it's just before radiotherapy or whether it's more of a long-term exercise before radiotherapy, or whether it's just before someone has radiotherapy, if we can look at ways of making that more effective. But the really good thing, and then one of the other really interesting things I think about exercise, is that it can actually have its own impact on the tumour itself, independent of any other type of treatment that people are having. And there's a diagram here that, if anyone's interested, you can look at the paper in more detail after. It's Daniel Galvao, who's based out in Perth. And they have looked at lots of different mechanisms and potential ways that exercise can actually influence the tumour and the microenvironment of the tumour, or how it can actually help have an impact on people's survival. Loads of different mechanisms currently out there, whether it's to do with inflammation or immune function. And one of the ones I particularly like from a prostate cancer perspective is this idea of reducing the amount of circulating testosterone. If people can undertake more resistance exercise and build muscle, apparently the muscle can actually act as a testosterone sink and pull a lot of the circulating testosterone out of the system in that way. So what we're seeing is that potentially exercise can help with disease progression, but also actually improve survival as well. So it's really exciting from that perspective, and it's not taken away from the other impacts that exercise can have around symptom management and quality of life, which I think are an equal, if not more, importance in some cases. But it's lovely to see that we actually can have an impact on progression and survival as well. So where is a lot of this coming from? I'm just going to talk through this. There's quite a lot of information on this slide. We've been starting to see some epidemiological data around how physical activity can actually influence people's risk of developing prostate cancer and actually their risk of dying from prostate cancer. And we've this really nice study from the States, the Health Professionals Follow-Up Study. It was around 1986 that this survey was started, and they have almost 50,000 men who fill in questionnaires every other year, looking at sort of lifestyle questions around diet and exercise and health. And over this time, I think there was about 6,500 men that were diagnosed with prostate cancer, and they were able to start doing some analysis to look at associations between the men's level of physical activity and their risk of developing prostate cancer. And what they saw was there was an association between a reduced risk of developing a more advanced type of prostate cancer, but also of developing a more lethal type of prostate cancer. So in the advanced group, men who did an awful lot of vigorous activity, so I think it was about 25 minutes of running a day, had a significant about 30% reduction in risk of developing advanced prostate cancer. And they saw similar with this developing a more lethal prostate cancer. So the TMPRSS2 ERG is one of them that we would hear people talking about that is more lethal. Again, those men who did a lot of exercise, quite vigorous activity, had about a quarter lower risk of developing that prostate cancer. So the key thing to remember about this, and it's crucial as we move on to the next couple of slides, is this idea of dose, and that it seems that it actually is dose dependent, the impact on risk, that it's a high level of quite intense activity that seemed to be the key in reducing the risk of developing an advanced or a lethal prostate cancer. And we actually saw this again in prostate cancer survival, and again this idea that it actually is dependent on dose and the actual level and intensity of exercise. This data was brought from the same study. And what we saw was that there was a reduction in all-cause mortality, so death from any cause, but also prostate-specific mortality. Now, I think this statistic is phenomenal. Men who did more than 3 hours a week of vigorous activity had a 61% lower risk of prostate cancer-specific death. Now, a lot of the oncologists that I would speak to, and we talk about exercise and we talk about the impact it can have, and they say that it's a type of risk reduction and things that they could only dream of sometimes for some of their chemotherapy or radiotherapy. So it really is phenomenal. But the key thing with all of this is that it's vigorous, that it's high intensity exercise is what we're seeing that actually is having the impact on survival. And again, we saw that also with all-cause mortality. They had a reduction of about 46% for men who walked more than 90 minutes at a very brisk pace. But for prostate cancer specific, it was more than 3 hours a week of a very vigorous activity. So this is kind of showing us associations. It's not really showing us the definite evidence for the fact that can activity levels and exercise actually influence prostate cancer survival. So this question, Movember decided to take this on and see if we could actually properly, definitively answer the question of whether exercise can actually influence survival. And I think this campaign and this project probably started a way back in 2014. Movember a group of prostate oncologists and also a group of exercise experts out in Perth. Rob Newton, I'm sure a lot of people, if you're interested in exercise oncology, you're bound to have heard of Rob. They kind of developed this protocol for looking at this, and you can see that it's intense exercise, and the rationale for that very much came from the growing evidence from the epidemiological data that it seems to have to be a high intensity vigorous exercise to really impact survival. So we were fortunate enough in Queens and with colleagues in Ulster to be able to be one of the sites delivering this intervention. So it's been actually a really exciting programme to be part of. So I'm going to spend a bit of time just talking through it. So the aim of this then, this is HIIT training. So we're looking at high intensity interval training, and we're looking to see, does it improve overall survival in men with metastatic castrate resistant prostate cancer. So it's a very advanced prostate cancer. Now I will never forget the first time when we took this proposal to some of our oncologists and the physios in the cancer centre, and I said, we're going to start looking at high intensity interval training with metastatic castrate resistant prostate cancer. And they all looked at me. They've known me for a long time, thankfully, otherwise I think they would have just shown me the door, but they looked at me like, you have actually lost your mind to think that you're going to do some sort of aerobic and resistance training with men who are metastatic. But thankfully we were able to talk through that a little bit, and we were able to demonstrate that this is high intensity interval training, and these pictures are what you think about when you think about people doing HIIT training. You think about fit people sprinting up and down hills and things like that, but it's absolutely not like that with our men with prostate cancer. Everything is prescribed and individualized, and yes, we want them to work at a high intensity, but for them it's not necessarily going to look like they're not necessarily sprinting. They're on bikes and they're just getting their heart rate to a certain level that would deem to be at a high intensity. So this is what the study looks like. Two groups, obviously it's a randomized controlled trial, and men are either randomized to an exercise group or a control group. It's a 24-month study, so they're in the intervention for a long time. 12 months is supervised exercise, although along that 12 months they tailor to self-managed, so the supervision is reduced over that time. We work in cycles, in monthly cycles in that way, and the amount of support and supervision tails off, because really what we want is men to be able to progress to being self-managed and doing the level of intensity that we want them to do in a safe way, but that it's sustainable over a long time. So as I said, it's all individually tailored. In the slide before you saw, they do a cardiopulmonary exercise test that we can actually, that first of all, we know it's safe for them to stress their heart in that way, and that the program can actually be tailored to them personally. It progresses, so hopefully they'll get fitter over the time. But a real key component about this study is that it's auto-regulated, which is a notion about the fact that men can change the program and change kind of what's expected of them dependent on how they're feeling on that day. And I think that's really, really important point to get across. If they are feeling very fatigued, or they have some pain, or they're just not feeling up to it, they don't need to do what is their prescribed exercise for that day. It's recorded, and they record what they will actually do, but then they can catch it up maybe on the next time that they're in and they are feeling a bit better. So it's looking at the program and the exercise as a dose, but an overall dose, and how we can actually be flexible with that. So the exercise program, as I say, 12 months supervised, 12 months self-managed. They get behavioural support to help them with engaging in the exercise, some psychosocial support as well. And then it's compared with what initially was just psychosocial support in the control group, but then everyone in the project kind of trial kind of thought that we can't be getting people to not exercise. So what if in the control group they kind of have self-led exercise, but it's not a prescribed high intensity program. It's the normal exercise recommendations that Liz had mentioned previously. So who's eligible then? Today we'll not look at an awful lot of detail around exactly who these men are, but I think for today the key to get across is that they can take part in this exercise, so they've no non-contraindications to high intensity interval training, so no congestive heart failure, peripheral neuropathies, no recent cardiovascular events, whether it's a TIA or heart attack or something like that. They need to be able to obviously complete the CPET, so we know they can safely exercise. And also men are excluded if they're already reaching that sort of target level of exercise, so more than 60 minutes a week of vigorous aerobic or more than 2 days a week of resistance, and those guys were actually excluded. Oh, and one other thing to point out actually is that there's been a protocol change that we can actually now start to include people that are hormone sensitive, so they haven't actually moved to that castrate level yet. Now in the UK that's not through the ethical approval, but some other countries are including those men in the programme as well. So this is what the intervention looks like, and as I said, it's tailored and particularly tailored to where men have their any METs. So obviously the aerobic and the resistance training is changed depending on where a site might be, where there might be some issues, and that is all very much regulated by the Exercise Coordinating Centre in Perth, that they keep an eye on everything, because what we don't want is to end up with a spinal cord compression or something like that, so that, or a fracture, so that everything is done in that safe way. So it's a mixture of resistance training and moderate intensity training on 3 days of the week. And as I said earlier, I really like that it has this idea of auto-regulation where we can kind of change it about a bit if people aren't quite feeling up to it on a certain day. So our primary endpoint's overall survival, but over 5 years, we're also looking at a number of other outcomes, disease progression, if there are any skeletal related events. And the other nice thing that we've got in this is that we're looking at to try to work out the mechanism and to look at the actual, why we're having that actual effect. So there's, we're looking at biomarkers of 3 different candidate pathways. So whether it's inflammation, insulin or glucose metabolism, and also androgen biosynthesis are the 3 things that they're looking at to see if we can, if they can work out the sort of pathway of how exercise is actually influencing overall survival. So this is the first trial to look at exercise and survival among men with metastatic prostate cancer, and we're really hoping that we can get that evidence to actually support the introduction of this as an actual treatment that actually will impact people's overall survival. So we're working hard on it. COVID's obviously had a big impact, but we're trying to push through that. We can maybe discuss some of that afterwards and how we've managed those things. But what I also wanted to mention is a local study that we're doing, which is called EXACT, that is running parallel to interval. So this component, this part is interval, so I'll just take that out. But what we're actually doing is running a home-based program for men who are ineligible for EXACT. So for whatever reason, they're not able to take part in a high intensity training. We are also offering them a home-based exercise because we thought it was really important to try and offer all men an opportunity to take part in some sort of an intervention and really to get the benefits of physical activity as well. So this is more moderate intensity, 12-week program and a mixture of aerobic and resistance exercise. And I can give folks information about this afterwards if anybody wants to know anything more about the EXACT program. It's an adaptation of a program that colleagues had used in colorectal cancer, and we've now taken it and looking at it in prostate cancer. But it's nice because it means if we screen first for interval and high intensity, but for whatever reason, whether it's the oncologist feels it's not suitable for them, or they have their screen fail, we can offer them this program as well and see if we can get the benefits of exercise for everyone. And we kind of really feel that if these are guys that are metastatic castrate-resistant prostate cancer, if they're ineligible for a high-intensity program because of some sort of cardiovascular issues, if we can get these folks to exercise, I think we feel we could probably get most people with a cancer diagnosis to exercise, because these are really probably the people that are at the sickest in theory. So that's why we're also really wanting to focus on them as well. So just very briefly then, before we finish, I think it's really important to look at challenges with this type of research. And one of the big challenges that we have, this is not just exercise oncology, this is any living with and beyond cancer type work, is funding. And I always like to show these slides because it really highlights some of the inequalities that we have around funding. And this has obviously only got worse with COVID and the pandemic. This is a couple of years old, this slide, but I'm quite sure it probably hasn't changed much. With the NCRI, so the National Cancer Research Institute, all the different partners, you can see the funding that's available, and the difference in the spend on cancer biology or cancer treatment is massive in comparison to what we kind of have, I've grouped together, sort of survivorship, living with and beyond cancer, and different things in there. And you can see that the small amounts of money that are actually available, patient care and survivorship was 9 million. And you can see that in comparison to biology and treatment. So it's not, I'm not wanting to ever use it as an excuse. It's just to show that the difference in the availability and funding that's actually there. And an awful lot of the cancer research funders have often very explicitly said that unless it reduces risk or influences survival, they won't fund it, which is why we've also been working really hard from an exercise perspective to demonstrate that exercise can reduce risk and can actually influence survival. And that has been sort of a discussion and conversations that have been going on for a number of years to demonstrate that, to also open up some access to other funding as well. Some of the other challenges then, so I've talked about interval, and we have this sort of discussion a lot around GAP4 and how specialist it is from an exercise perspective, that you need exercise physiologists, you need exercise experts to deliver the program, to run the CPET, to safely prescribe the exercise. And it's really important for interval that it's done that way because of the epidemiological evidence. And it's saying if you want to influence survival, you have to be exercising at this high intensity. And that's obviously the optimal dose, but you really have to balance that with pragmatism and what can actually be delivered in the NHS. And there's definitely two camps in this, I think, in exercise oncology of people who are, no, it's got to be complete high intensity, or there's no point. And then there's others that's more to do with implementation and how we actually get people to exercise. And surely it's better to get somebody doing something if it's home-based and moderate intensity than nothing. And I suppose it depends on what you're wanting your outcome of the program to be as well. I think when I started interval, I was very much of the optimal dose. And I think as time has gone on and the difficulties and challenges that we're seeing, I think I'm probably moving away and more towards the pragmatic as well. So, and it also I suppose it depends on what you're trying to deliver. The trial has to be done in that way to look at efficacy and look at, does the exercise actually have this impact on survival? And that helps us then with that evidence and approaching funders and building arguments that this exercise influences survival in that way. But is it from an effectiveness perspective rather than efficacy? Can that actually be delivered in the current NHS and how the NHS is set up? Some centres probably, but definitely not all. And I suppose we find that a lot in not just exercise oncology. So I obviously sit on the NCRI's Living with and Beyond Cancer executive, and we're often trying to get multi-centre trials up and running in all Living with and Beyond Cancer trials. And that's probably one of our main problems, is this idea of complex interventions and they're really, really hard to deliver, and not all centres can deliver them. It depends who you've got at the centre and what facilities and equipment and everything that you have. So it's a challenge for living with and beyond cancer generally, I think, to be able to deliver any type of complex intervention. I also just put in here, but we can maybe chat about it afterwards, is this idea of the impact of COVID and how we've been able to deliver projects. Basically, what we've had to do is move everything to remote supervision or home-based on Zoom with people, able to supervise. So it has had an impact, but I think it's actually been quite nice because people have moved on, a lot of the patients, and they don't seem to be as reluctant to use the technology. And we did some work with Macmillan Move More, who has started their programs online to look at people's sort of engagement with that and their attitudes towards sort of a virtual delivery of a program. And I think people maybe have become a little more okay with it. I mean, I speak from myself back in March. The idea of doing everything online and would have been terrifying, but now it seems that things are a whole lot better. So it has been quite nice that it has moved on in that way. And then the very last bit, I guess, is this idea that exercise is behavioural, and how we actually manage to get people to engage in exercise is always going to be difficult, and how we actually keep people on track and get them to exercise is obviously a key thing. And Liz had spoken a lot about that, and we can probably talk about that as well in the discussion. That's me. Thank you very much.
Gillian, thank you very much. I think that led very beautifully on from Liz to both of you. And, there is quite established convincing evidence that exercise is so good. And at what level, I know we don't have the RCTs yet out for the results yet for the same therapeutic, but is there a moral sort of something there about, why are we putting people into trials, and why is it just not routine part of care as much as anything else? I'm going to throw that out to the both of you.
Yeah, and I think that was the thing that we came up against with GAP4, that we couldn't ask people in a control group to not exercise. And I suppose it's, from my perspective, what we're trying to do is work out optimum dose and optimum timing, and when people should be exercising and at what level they should be exercising. I think from a symptom perspective, from a fatigue, pain, there's level 1 evidence, absolute solid evidence that exercise is only going to benefit, it's only going to do good. From, I guess, from the survival perspective, there's still some work to be done. And I suppose it's the optimizing of it. What should someone do and when should they do it to get the maximum benefit? But you're absolutely right that there should be no trials that are going at the minute that ask people to not exercise.
Or even more than that routinely in whatever cancer you've got, because we can sort of take it relatively confidently, that the exercise program should be integrated within the routine care.
Yeah.
Liz, I don't know.
I think the hard thing is to prove this should be nationwide. You need the trials to prove it has a benefit to then get the money to help other centres institute it, which is a problem. And it's very hard. It's a bit like any trial looking at diet. How do you make sure that someone is doing the exercise they say they are doing at the intensity they say they are doing? And that's why you do need the trials. But everybody should be told to do a bit of something. I think if you're not telling them to exercise, you're doing them a disservice. But again, it's, what do you say? Someone who's got COPD, endostoma, who's had bowel cancer, do you feel safe saying they can go to the gym? So those the Can Rehab, Anna Campbell up in Scotland trains level 4 PTs and how to train cancer patients in a gym, what exercises they can and can't do. If you don't have access to that, someone may give you something that is actually dangerous, and it's how you get that information out there.
And also, I suppose then starting at different levels, like a little is better than none. I think it is very interesting how, the more vigorous exercises are, the more therapeutic. And we have thought a little bit in the past about going out for a walk or something, or a vigorous walk even, but it's much more than that, resistance training and things like that, but which can be integrated into your own home and don't need to be in.
If you take during COVID, Joe Wicks and his, PE at home for the kids, people doing that. It's half hour. It is saying it has to be hard. You have to be sweaty. It won't be pleasant to start with, but you will get better. You can easily do it at home.
So colleagues who are on call, we're all muted at the moment, but I would ask you to unmute yourselves and just ask any questions or have a little chat. You know, I know there's various things going down in the chat form that we can bring out, but I'll just throw out the forum openly to the complete group.
I would just like to thank both Liz and Gillian. That was a really interesting morning there with two talks that very much dovetailed nicely together. We were hearing from your personal experience, Liz, and the key benefits, and then from Gillian a little bit more about the science behind exercise. This is a question for Liz. I have part of my role is clinical, and working in head and neck oncology as a clinical team, we are much more convinced now than what we would have been a couple of years ago about the benefits of exercise. Increasing evidence coming to the fore about early engagement in that prehabilitation. Any tips in and around promoting engagement with our patients at that very early phase? And they've just heard they've got a cancer diagnosis, they're going for multiple scans, multiple appointments, life's quite chaotic. How can we enhance engagement early?
I think I would say the thing I hated most about having cancer was that I lost all control. I had no say over what was happening to me. I had no idea whether the treatments would work. I just had to let people do stuff to me. And I think hearing that exercise was something I could do to take back a bit of control. My cancer still came back despite me exercising properly, but my risk was reduced. And it's saying, this is something you can do, you can take charge of, that will help you. And get your family on board so you're doing something together to build that sense of we're a unit going through this, rather than prescribing it as hard work. It's like, does that make sense? Empowering them to say, you can take control of this. This is something that we know will help. It will help make you feel better. You can do this. It doesn't cost anything. I think exercise is often a dirty word to a lot of people who think, what do you mean I'm having chemo radiotherapy or cutting my tongue out and I have to go to the gym? And it's knowing what's available. So having almost digitally signposting them, right, we know you need to do this. Here's a couple of videos you can look at. Here's an online exercise class. Have you looked about this? Give them something to go away and look at as well, rather than leaving them to find it themselves, because you've got so much information, you need a bit of spoon feeding. But I would say, tell them that they can help control their disease that way.
Yeah, and that's interesting to hear, because that would be an approach that we would take, proactive, but the sense that there's parts that we can do, but there's certainly as a person, as a patient, there's things that you can do. So that's great.
Yeah.
And just for Gillian, I picked up in the term, and I did put into the chat about safely prescribing. We know that our patients have multiple comorbidities. We're talking here about the high impact exercise. I'd just like to unpick that term, what you mean by safely prescribe.
So no one's allowed or screened for interval. They have a cardiopulmonary exercise test, ECG, to make sure that from a cardiovascular perspective that they're safe to take part in. From an aerobic perspective, high intensity. We access all their scans to see where their METs are, and then they will only get a certain aerobic activity, or they'll only load a certain bone that's not at risk of fracture. So the team in Perth have this lovely little table of exactly what you do dependent on where their METs might be, so it's safe in that way. And then it's prescribed that we want people to work at a certain level, but it's prescribed obviously based on their own level of fitness. So for some men, to get sort of an 80% heart rate, that might just have to be a bit of a cycle to get them to that level, because they could be very deconditioned. Well, they definitely are very deconditioned by the time they get to this sort of advanced stage, and then have been on hormone for a long time as well. So it's kind of all relative to them and their level of fitness.
So could I just pick up on that, Gillian? It sounds extremely targeted individually.
Yes. Yeah. Like each person they're all doing aerobic and resistance, but they might be doing it slightly differently. Mal, I've just seen Malcolm has commented on the chat. He's the fab postdoc. He's the exercise physiologist that runs Gap 4, so he can probably, I'm probably doing it a massive disservice. But
Come on.
You're here, if you want to chat a wee bit more about it, certainly feel free. Talk about putting somebody under pressure.
Is he biting you, Julie? Biting the bait?
No, I don't think you've done a massive disservice at all, Gillian. I think that's exactly right. We take it on a case-by-case basis. We assess the guys beforehand to determine any sort of metastatic disease that they might have, as well as their overall level of fitness, and taking into account as well their comorbidities, and we tailor the exercise around that.
So in a sense, you know, and maybe my very first comment about, you know, the morality of knowing exercise is effective for various reasons, that's where health professionals, and I think Tamara has mentioned this above, that, you know, this should be just within routine care, but maybe we need to think, and in the future, for future research, that there are different programs of different levels that we can routinely prescribe, and then maybe do some sort of an assessment. And then we're talking about, you know, what you're speaking about there, which is, you know, does have its time challenges, etc., etc. And I think probably you touched on that, Gillian, about the NHS and how realistic is it long term. And we hope it is. And there could be computer algorithms or anything, I suppose, in time, but I don't know.
I mean,
comment on that.
When we first started this, I suppose I had to really work on the mindset of some of, not all the oncologists, but some of them, and we talk about people's radiotherapy treatment, and you're automatically expected to come up 5 days a week for 6 weeks, or, you know, your chemotherapy treatment, and it's changing that mindset of this. We would hope, our ideal is that this is seen as a treatment, and this is because people have to come up to the cancer centre 3 times a week for this exercise, but we don't want to see it as an add-on. This is actually one of their treatments that's prescribed.
Yes.
Like you would prescribe their radiotherapy, and yes, they might have adverse events, but you have adverse events in radiotherapy or chemotherapy. You have a dose reduction if people aren't tolerating it, and that's how we need it to be seen to influence people's survival, I guess. And that's where the conversation sort of initially started, and we got people to understand that. I think it's been good.
I would love to see every single patient sees an oncologist, a surgeon, a radiotherapist, and an exercise physiologist or personal trainer. It happens in centres in Denmark and in the States, and I think that has to be what we're pushing for, so everybody can get their own personalised exercise prescription. We're a long way off, but these trials will help.
Well, these trials will help, and there is something also in that about hooking people in, because especially they're quite, at the beginning, they are probably there's a readiness to learn there at that stage, which we need to capitalize on and get the mind shift early.
Whilst they're well, before the treatments have started, they can get the benefits, they can learn. It's
We're hearing the word mindset, so mindset for clinicians to engage and promote, and then mindset for our patients as well. So I have to say that's very good.
Jeff, do you want to come in, Jeff?
Yeah, thanks Liz and Gillian. That was really informative and very helpful. I was just thinking, taking on a little bit from your comment, Liz, and saying about this is an opportunity for people to take control back into their lives. And considering a lot of people are attending gym classes, going to PTs, etc., what sort of lessons are there for them to learn? Bearing in mind that, you know, exercise intensity will vary for individuals on what they cannot do. What sort of key lessons for them based on your research and personal experiences?
So I think for me, it's realizing that you can do a lot more than you think you can. And I started thinking, I'm having chemo, I can't lift weights in the gym, I've just got to do a baby bodyweight lunge, and it was rubbish. I can actually lift heavy, I can. And you set limits on yourself because you think, I'm having chemo, I'm sick. So they did a thing in Denmark where they introduced everyone on chemotherapy would have personal exercise sessions 3 times a week. And they told the chemo day nurses this would happen. And the nurses said, our patients can't cope, they're having chemo. They can't go to the gym. And they took the nurses to the gym, and the nurses realized that their patients were fitter and faster and slimmer than the nurses were, who weren't doing any exercise and they were healthy. And it's a massive preconception that cancer patients are sick. A lot of them, apart from those 5 days during chemo, feel well. And actually, you can work harder. You need someone to push you. You don't be scared of going hard, getting sweaty, actually getting your heart rate up, and push yourself. And it is meant to be a bit uncomfortable, because that's how you get the benefits from it, rather than staying in that safe, I'm just going to read a book on the bike, which doesn't do anything for you. And I think that's where talking to others and reading what other people are doing like you, or they did this, or maybe I could, it's okay. That, I think, is how we get the word amongst patients to realize, I'm doing this, have you not been told to do that, or try this? And they might spread the word at the grassroots level to go up to the doctor saying, oh, we really need to tell them to do it. Gillian, what do you think?
Yeah, no, absolutely. And I think it definitely is that behavioural type thing, and that belief in whether or not people, think they can do it. And I mean, we're about to start, well, we kind of have sort of, but COVID influenced it a wee bit, looking at exercise with pancreatic cancer sort of during treatment. And a lot of when we spoke to people with pancreatic cancer, a lot of what they thought was that it would be really good to hear, because I think of the stories they told us was when they were diagnosed with pancreatic cancer, they kind of thought, so what's the hope? What's the hope? They maybe have quite a negative or difficult prognosis. And they said to us, if their oncologist was saying to them about doing physical activity, they would see it as, well, all hope is obviously not lost. If my oncologist thinks that I'm going to be okay and fit enough to undertake some sort of a program, this is good news. They saw it as a bit of a motivating factor, that it wasn't just, well, we're giving you chemo and all you're going to be able to do is lie on the sofa, and those are things that I didn't think of, that the impact that would have on the patient's perception of themselves, to kind of think, well, if he thinks or she thinks I can do this, it mustn't be all bad, and it shifts that expectation too, I think.
So an example of a friend of mine, she's got metastatic breast cancer. She doesn't have long to live, weeks, but there were things she wanted to do, but she couldn't walk. And we followed the advice to do the squats and lunges, and she could do 2 squats, and within 2 weeks she's now doing 3 sets of 90 squats a day, and she can now walk upstairs, and she now has the strength to think, I can go and do my bucket list thing because I'm suddenly active. I can walk upstairs, I can get off the toilet, whereas before I was sat in bed thinking I can't do anything. And that's just 2 weeks of simple body weight squatting. It gives patients the ability to live however long they have the best they can, than just sit in a bed, you're done for, which is what a lot of doctors think. Because again, if you don't exercise yourself, you don't see the point in telling patients to. So it's that medical mindset as well as the patients.
Absolutely. Mary Hockey, I don't know if she's still on the call or not, but she had an interesting question there about high risk.
Yes. Hi, Eilís. Thanks very much, Liz and Gillian. I thought that was fantastic, and I was really interested to hear. I suppose one of the things that we looked at, because obviously McMillan have the Move More programme, we had linked in with our family history breast team, because they had been to a conference and they were saying that if people exercised, had a healthier BMI and reduced alcohol, that would reduce their risk of breast cancer for people with a family history by 30%. And I just thought, oh my God, that's amazing. So one of the things that we've been trying to do is to try to encourage these ladies to avail of a healthier lifestyle. And we have linked in with McMillan Move More to try to get our doctors then, when they come for a consultation with these ladies, they are signposted straight into McMillan Move More. So it's not that they've had cancer, but it's just that they're in that high risk. And I just think there's probably a whole lot more that we could be doing. I'm sure even for some of the gynae type patients, because BMI plays such a risk factor, I think, isn't there, for all cancers. But I suppose it's just it's a wee bit before the prehab, but it's a bit about those people that potentially could be at risk, and that we need to be getting the message out. And I think it's just that thing what you've said all along with both of you is about, exercise is like, the new pill, really, isn't it? I mean, we should all be people to lead
and I think
your lifestyle end off,
There's no point in telling every GP to tell patients to exercise. I need to tell them what to do and how to do it and make it easy for them. And that's where knowing there's a Moving On program, or did you know the council does this, or there's this video, so you can say, here you are, go and have a look at this as a starting point.
Yeah.
Telling them about the 5K your way or the couch to 5K, something that they can do. Right, here you are, I'm making it as easy as possible. Because it is hard work. Most of us don't have the time. I didn't exercise properly for about 7 years until I met my husband. I was just too busy. I didn't get it.
I know. And Liz, can I just say, I think I picked up with you as well. You were saying about the peer support.
Yeah.
I think, is that something that we should be looking at? I know within our trust we have our promoting wellbeing team, and we do have a general physical activity strategy. But I'm thinking now that we, in Ireland, we're developing our cancer strategy, and then maybe we need to be a bit more targeted in terms of, and the peer support, I think, is a huge element of that, isn't it?
So I think, I know for me, I love the park runs, the 5K away, because you meet people, you say, I'm going to turn up because you're going to be there. It holds you to account. It's nice to talk and chat about anything but cancer. And it was just a way of making sure that I turned up and I did it. I like exercising in a gym and a bike by myself, but it's very easy to forget that. But it's that peer support. I'm struggling, you're struggling. How can you? And you learn tips. And there's another prostate group in Sheffield. They're talking the men in the gyms, and actually they loved all being there at the same time when we were all doing it and comparing. And I think it's really important to patients. I didn't meet another patient through the whole 9 months of treatment. I didn't meet another breast cancer patient. I had no idea what was normal. It was all through Twitter, and that was my kind of support. But once I went out and exercised with other people, it was suddenly, oh, okay, I'm not really, really fast, slow. I'm actually normal for people at my level. And it was, again, it's a way of forgetting you've had cancer and just being a normal person. You must find that with the men, Gillian, when they're all training together.
And it's just some of what Mary said there about, people maybe with a higher risk or a family history, and it links back to what Liz said about this. It's maybe that idea of control. It gives them something that they can do, to kind of help.
And then they get the family and the kids exercising, reduce your whole family's BMI, and then it's that whole kind of, it's not just the cancer patient. Get your family to do it with you.
Yeah.
And then we'll cure diabetes.
Exactly. Sorry. Moving on to that, Assumpta, are you still on the call? Because Assumpta had put in a question that she's from a different clinical background, and how does that fit with your population, Assumpta?
Well, it's very different. I work with people living with dementia, but in a recent study where we were looking at the impact of technology facilitated reminiscence, we worked with 60 people living with dementia and asked them to use an iPad app to support reminiscence. And we found that they reported very positively on the expectation that we had that they could learn a new skill, that they could take ownership of this condition, and that they could do something other than sit and wait for the dementia to progress. So there are very, very many similarities, and we weren't expecting that as an outcome, but that was, that was really, really very significant. It's something that we will be factoring into other studies. But I'm also interested, and I have another meeting shortly, in access to services and support in the context of rural and urban jurisdictions. And is it the case that access to a gym is a requirement for either recruitment to these studies or for real engagement with this level of long-term activity? I live, as you can imagine, in a rural area, and yes, I can see how the online would work, but thinking about how Liz, you talked about, that peer support that you get from being with other people, the nearest gym for many people could be 10 or 12 miles away. So, are we automatically excluding people, or maybe failing to consider the unique, particularly of a very large rural population here?
I think it's the aerobic exercise that the peer support comes into play, meeting up for walks, for the runs, for playing tennis, swimming, again, lockdown permitting. I think that's when peer support helps. I think the resistance, most people will end up doing by themselves. And you can do that at home with a resistance band and a couple of tin cans. Whether you WhatsApp someone, so you're both on your phone doing it at the same time, you don't need to be in a gym to exercise. And that's really important, because you can get a real rich-poor divide. You can do weight resistance training, body weight training at home using simple YouTube videos. And you could say, right, we're both going to plug in and do this at the same time. How is that for you? It has to be free, very, very cheap, so everybody can do it, and money is a limitation. But I think outdoor aerobic exercise with the peer support will really help people. What do you think, Gillian? Do you find that with?
Yeah, no, I agree totally, and I think that's been one of the, I always try to think of positives and things. I think it's one of the positives of COVID that's been it shifted us to kind of think of doing things online, which is obviously hopefully more inclusive. I mean, I appreciate maybe not everyone can maybe get themselves online, but I think everyone has kind of been pushed towards it to keep in touch, you know, from grandparents and grandchildren, and we've kind of just found that it's, you know, a few years ago people would have been like, oh no, you can't do it online, people over a certain age won't use whatever, and I think that COVID has definitely shown that that's not the case at all, and people can and will, and it has made us look at that too, because it is obviously an issue that but this has kind of helped us to think of ways to come around it, and I think to not always be so set in the one way of this is the way it's got to be done, you know, and be more flexible and pragmatic, I guess, at times.
Totally. Viv, I see that you have talking a little bit about health professionals themselves. Like, I mean, it does come back to, but they're only one group. But Viv, are you there? Maybe Viv is being
so interesting and well done. I was just thinking how my background is in diabetes, and we've been doing some work about obesity, and when we were looking for approval to do some work with obesity programs amongst patients, one of the directors of nursing said, "Gosh, Viv, I wish you would do something with staff." And they're worried about staff and the number of maybe not physios, I don't know about physios, but certainly in doctors and nurses is quite a problem with that. So I could just imagine that if our own staff don't think they do very much about health promoting, trying to sell this to our colleagues is an achievement. And I just have a general comment, just a small piece really, but I suppose this is a growing movement. I was thinking, a long time ago, I forget quite how many, but at least, I'd say 15 years ago now, my husband had a stem cell transplant, was in the city hospital. And I know whilst he was in isolation, they moved in a stationary bike. And they said, if you can cycle all your way through this, even the days when you don't feel you could get off your bed, no white cells, and, you know, they said it helped. So maybe that was at an anecdotal evidence, but certainly post-stem cell transplant patients about 15 years ago were being told, if you can cycle your way through this, it will pay dividends. And so maybe they just knew that anecdotally, but this has been on the go. And I think what you're doing is very, very inspirational. I'm really impressed.
I think that's an amazing story, and it's happening more and more of getting exercise bikes into people in isolation. But just coming back to healthcare professionals, I think I used, when I went back to work, I would tell patients to exercise, and they look at me and say, it's easy for you, you're slim. And if I weigh 30 stone and I tell patients to exercise, they go, really? You look like you haven't got a pair of trainers. It's very hard to persuade patients to do the right thing when you don't look like you do it yourself. And I'm not sure what the answer to that is, but I think, like with 5K Your Way, with the trying to get cancer patients to do it every Saturday, I was trying to get the local doctors and nurses to come and do it. Join us, do it with us. We know it's hard, we're here. Can you start something where some members of staff do it with the patient so they can see that we're all suffering together? It's really, really hard because no one has the time. And if we can't find the time when we're telling patients to do it, then what's the point in patients? And I don't know how you change that culture, but it's so important.
The other way it could be turned as well, that if you were doing good health promotion with healthcare professionals who didn't look, because I would, you know, when you meet somebody, they look very athletic, you do feel a little bit, you sort of, well, that's okay for them. Whereas if you're meeting somebody who is overweight or, you know, doesn't look as if they take care of themselves, but have managed to get the message, I mean, that they could be quite inspirational to the person because you can identify with them. So that, but I think it's that we probably need in the workspace, you know. So
when the world opens up, do you have very cheap exercise bikes in clinics? So all clinics overrun, you know, come on, do your 10 minutes. We're all, you know, put your Polaroid on, I've done mine. Really simple things like that to make it part of hospital life. You know, do your laps around the hospital whilst you're waiting, come back in 10 minutes. Okay, good, next. What's the step count of the clinic of people waiting? Little things you can do just to make it fun.
But something so simple as exercise bikes, just there in the waiting area where you're waiting for half an hour, anyway, in itself. I was doing a course in Michigan, and you know, 15 years ago we went for a visit there at the University of Michigan, and they were on treadmills, the staff were. while just to get up and, I mean, I know we're moving towards that a lot ourselves now, but 15 years ago they were writing their notes or doing their emails on treadmills, you know. So there is, you know, ways at the workplace, but it's that hook and trigger. But I think it's a really important point, Viv. So just to the bigger group, Cherith has put out that is there any other questions? Does anybody want to pop up or say hello or any comments? I'm just throwing it out to everybody. You just unmute yourself and say hello. Any last comments?
Hi there, it's Lawrence Taggart here, one of the readers in the Institute, and my area of background is learning disability, and you may say that this has nothing to do with people with learning disabilities, but I think for people with learning disabilities, they have a high rate of obesity and health problems that can lead to premature death, and we've been doing some work around trying to look at health promotion in this population, and it comes down to systems. And how do you change culture? And I think what Gillian said, one of your studies you're currently doing with a PhD student is around implementation science. And I think that's what we also have to think about. There's been a lot of good talk this morning around behavioural interventions for individuals, like peer support, park runs. That's excellent. But it also comes down to systems having to make changes, you know, and that's what we've been looking at. And we're trying to work with organisations. One of the organisations that I work with at the minute is an organisation called Positive Futures in Northern Ireland that's looking at how to train staff up in positive behaviour support to manage those adults with learning disabilities who display aggression. And it's not just about giving the staff training. If you give the staff training, that's not enough. We have to change the system where staff are allowed to put in the training. And
Could you give us a little bit of example of what that means?
Yeah, we're using this thing called logic modeling, where we're sitting down with the key staff who can make change happen, and it's all through co-production. So it's not just we're coming in with the evidence, the theory, but we're actually sitting down with the people in practice and saying, well, what's going to work in practice, and having this negotiation. And then by the end of the co-production period, 3 to 6 months, then the organisation has made a logic model where they're putting in outcomes, and the outcomes aren't just for patients, but there's outcomes for staff and there's outcomes for the system that they're trying to look. And very importantly, they're looking at what is the mechanism of change to get that final outcome.
So interested to hear the different populations, and I mean, definitely it's not a one answer fits all, and I think that's been really helpful. Karen McCaughan, who is a new PhD student. Karen, could you make yourself, because you're sounding as if some of your work is a little bit related to this, and what you've got out of today, and maybe how you might go forward differently or anything?
Yeah, Eilís, I have just started there with Jackie, Gracie and the team there in Ulster University last few weeks. We'll be looking at exercise intervention, and particularly we're aiming to look at Pilates. But what Gillian was saying was really interesting because of obviously COVID-19, and looking at doing a lot of this online, I think is going to be quite significant for us. But it was great to hear that how exercises has such a massive impact on the management of fatigue, but it's just bringing it forward and having those behavioural theories and models in place for patients like this, because I've just come from the clinical background, so I've come straight out of the clinical world in Northern Ireland, working with cancer patients and haematology patients, so I know my experience of how we deal with it, and obviously the Move More programme has been massive for us here, so this has been really interesting for me, thinking about my project and my proposal going forward.
That's
good luck.
Yeah, and good luck, and start. I think coming from the clinical area, you will bring a realism to your project. I mean, that is just such an important ingredient, that you know what you'll be purporting or how you'll be exploring it will be in the reality of our health service.
Yeah, and knowing that fatigue is a symptom that patients express during and post-treatment, but coming as a nurse from that world, we don't talk about giving exercise as a prescription. So hearing it from Liz and seeing what she went through is really eye-opening for me as a professional, to say we do need to change our perspective on how we look after these type of patients post-treatment, with all the HNAs that are in place and survivorship and all of that, what we're doing, but we're not talking about it maybe pre and during treatment, and emphasising it post-treatment. But having exercise prescriptions is something I'd be really keen to look at, because I wouldn't know what type of things to say. We'd send them to the Move More programme because that's what we're educated to do, but we wouldn't be able to say, look at this video or look at this online.
Yeah.
It's just, there's just so much out there as well, that you be feeling that you want to make sure whatever you tell the patients is appropriate and safe.
So with fatigue, I didn't get it. I had patients complain that they were tired. I just thought, oh, really? And then you get what it's like to be so tired you literally cannot lift your head. I did not understand. And the last thing I wanted to do was to walk. So I did it first thing in the morning, so I'd earn the right to sleep on the sofa, and it got it out of the way and it was done. Because when you wait and wait and wait, and then stuff happens and life goes on. And so if you're trying to help patients to do it first thing in the morning, then you've earned the right to sleep on the sofa all day, and it's done and it's out of the way. And that can really help make them feel they've accomplished something, and then they can collapse in a heap.
Round up now. Again, once thanks to our two speakers, and definitely I think we'll be looking forward. Liz is currently writing a second book, but I have her first book and I would highly recommend it. And although it is for patients with living with breast cancer, many of the details and tips and practical things in it are applicable to the cancer general population, and the exercise chapter is excellent. So Liz, thank you very much for giving your time and sharing that experience.
You're welcome.
And Gillian, I mean, it's great to know in Northern Ireland that we're part of such exciting research that is really, you know, which you can anticipate on down the line, 5-10 years, is going to be in routine care, and the evidence will come out.